Recording bariatric surgery data is very important. In the UK, we have NBSR systems, dendrite company, and you can't put all the details of the patients on the system. You can't compare your data to the other surgeon data, and you see yourself what is your performance, what is your complications. And then BOMS, there is a committee in our British Obesity Metabolic Surgery Society, a committee, I think, of 5 or 6 people. They are analyzing the data every 1 or 2 years, and that will make it public as well. So every patient or citizens in the UK, you have the right to access these data. And about, I think, 4 years, the societies in the UK, they requested Royal College as well from every consultant surgeon to give his consent to publish his data online. So the publics, they know my mortality, my complications, they have a free to access all these data. So I'm just going to show you the website of MBSR. We are not going to go through the final details. I think the time will be very short and we have 3 or more talks to give. No access? Okay. It is NBSR. Just put it on Google, NBSR. You can access the web page. You can access BOM's website as well, British Obesity Metabolic Surgery. You find it there. There are very important documents to you as a bariatric surgeon on BOM's website. So you can see our guidelines, infrastructures, our recommendations, indications of operations, nice guidelines as well. They updated the management of obesity. It is a free documents, very important documents, lots of references in it, and I think it is beneficial to you. This is I think I will start with controversy of MGB. This is an important issue because it's very important to understand why there is controversy. These controversies are bile reflux, esophageal gastric cancer, afferent loop syndrome, stomach ulceration, liver failure, diarrhea, and malnutrition. Oh, sorry.
Technical.
I don't know why there is no connection. It's okay. لا هو ده يشتغل من الديسكتوب مو من
الكونكشن
بس. Just the connection.
connection مع الحاسبة ويا
Yes, thank you. Okay. لا مو الويب سايت. Forget about the website because we are short of time. So just go. Just let me see whether this video is working.
Hello everybody.
Can we increase the volume, please?
I want to talk to you about the problem facing existing men in this time and something that we're not talking about, and that is the oppression.
Hello everybody, my name is Muhammad and I want to talk to you about problem Omen by advice. My wife today told me to wash dishes. I said no. I said I'm in a house. I work all day. I come home. I don't want to wash dish. She said to me, well, if you don't wash dish, then I want to cook food. I thought she joked. I said, we will see. Anyway, 6:30 o'clock, no food. 7 o'clock, no food. 7:30, no food. 8 o'clock. She gave me bloody biscuit. I'd like to make everybody aware of this situation.
Okay, so there is no life without debates, and debates at every level, at our household level, in the work, in politics, in medicine and surgery, and this is natural. There will be no progress without debates. I present an idea, you challenge me, and you present your support for your idea. Is our debate similar to political debates? Well, I'm not sure about this. As you can see, UK political system is quite unique. The government will sit against the opponent, and the distance, I think, 2 or 3 meters. It is not far away. So that will make everybody is confronting everybody else and to present the weakness in the team who's in charge. So that will improve the system and will carry on to make system carry on in the best possible way for the best benefit of public. In research and in surgery, we should be doing the same thing. So I'm presenting an idea, you challenge me, you present the weakness in my presentation, in my new invention, in my operations, my approach, my management to the patients. And all that will results, should be resulting in a new pathway that's help improving the care that's produced to the patients. As I said previously, Professor Mason presented his omega loop gastric bypass, and he did his first operation in 1967. And he presented his initial data, I think of about 100 patients in annals of surgery with relatively good results, but because of severe bile reflux, it has been abandoned. So the facts about bile reflux after MGB are the following. We've done a study of 435 patients. It still is our patients. The paper has been accepted in International Journal of Surgery. It's going to be published 2018. Our bile reflux that needed revision is only one patient. So our incidence actually is 0.2%. Few patients, they complained with bile reflux and treated conservatively with medications, and they improved. It is not only from our observations and data, but you go to the MGB data and publish operations data for patients, and you can see the incidence is between 0.6 and 2%. The largest study is Kolar study. Kolar, he's practicing surgery in India, and he has a private hospital, and his incidence is 2%. Mosilla in Italy is a big name in MGB surgery. It's 0.9%. JAMO study 0.6%. Chevera in Paris 0.9%. It's not a huge number. So when we change from Roux-en-Y to MGB, the question to us, we are 2 surgeons, myself and my colleague, Mr. Shamsi Al-Hassani, we ask ourselves, what is our criteria for selection? So we went internationally to search for it. There is no criteria, there's no guidelines, no international guidance. Then we checked BOM's website. There is no guidance as well because there is no data on BOMs for MGB. And the first operation done in UK as MGB operation is 2010 by Sunderland Group. They published their first largest series is about 125 patients in obesity, one of the obesity journals, not a big journal, but because of the number, they couldn't publish it in obesity surgery, surgical endoscopy, the most respected journal. So the largest study published from the UK to date is 125 patients only. And our paper, if it's going to be published in International Journal of Surgery, will be the largest UK series, 435 patients. So our selected criteria, any patients who had hiatus hernia more than 5 centimeters will be excluded from MGB. So we suggested for these patients to have Roux-en-Y gastric bypass. If we scope a patient, because we are doing endoscopy ourselves for our patients, we don't depend on gastroenterologists or other surgeons to do gastroscopy. We scope them before the operation, so we know exactly what we are dealing with. Any patients who had grade 2 esophagitis or more, that's not for MGB. Patients who have been taking maximum acid suppression, PPI medications, orally, and they are still symptomatic, they are excluded. In addition to that, any patients who had history of Barrett's esophagus or family history of upper GI cancer, we will exclude them from our MGB series. What about preoperative OGD? Is it needed in every bariatric surgery patients? I don't know. Professor Bazoki said possibly we do OGD, but our local guidelines, we don't do OGD for every patient. At the moment, we are doing gastroscopy for patients who had more than 50 years of old, number one, because the incidence of paraesophageal hernia, gastric abnormality is higher. And we have patients, my colleague operated on a patient, she didn't have OGD before, and it was large paraesophageal hernia, actually, and he was stuck. What to do? Half of a stomach in the chest. What are you going to do? What is your option? So it's better to have preoperative plan and diagnostic gastroscopy before that. So there has been no guideline. So no studies are available on selection of the patients for MGB with gastroesophageal reflux, actually. So we stuck to our local policy. When it comes to comparison between MGB and Roux-en-Y gastric bypass, we know all Roux-en-Y gastric bypass is a curative for reflux disease because it will be shifting all the bile from the stomach, number one, and because of it is a small pouch, it will reduce the acid output from that small pouch. So that's the gold standard procedure for patients who are obese and who had reflux disease as well. For MGB, the story is different. Because of this concern about reflux disease, then we have to be careful here. So where is the evidence that MGB is not an operation for patients with reflux disease? If we come and study all published series of MGB or one anastomosis gastric bypass, the incidence of reflux, the average incidence is up to 0.7%. And this is large papers from Kohler, Lee, Rutledge, and Chevalier group. Paris, I think that presented the first slide in the first talk, so I don't need to repeat that. It is an animal study. They didn't find any changes in the lower esophagus when they exposed lower esophagus to bile. There is only one case of gastric cancer and ruminant stomach. It's not at the junction or in the lower esophagus. But from my experience, I think I have done up to 10,000 gastroscopy in the UK till now. When you scope patients, you will see about 10 to 15% of patients there is bile in the stomach. Does that mean all these patients going to develop gastric cancer? The answer is no. So it is common thing. So there is also studies has shown that there is no evidence from scientific study that merely presence of bile in the stomach can cause cancer. We'll go to the afferent loop syndrome. This is really serious complications after MGB. I'll show you possibly a video if we have a time actually about these complications. So afferent loop syndrome, where you have a blockage at the gastrojejunectomy. The bile will be secreted, as you know, by pancreas and liver, all accumulated proximal to the junction. That will cause distension of the stomach and distension of biliopancreatic limb. This is serious complications. Patients will have continuous pain. They can't vomit because it is blocked, and it is severe pain on the left side of the abdomen, especially in the left upper quadrant. But they are tachycardic, they are not well. You come in the morning, face day, and you see the face of the patients, you see observations, that's not right. So in the UK, we have the facilities to do CT scan to buy the time and to prepare patients for theater. But for you, I don't think you have the facilities here in Iraq to scan patients who they are unwell. So the answer is immediate laparoscopy. Don't delay. Every minute will be count here. I'm not going to go through the physiology. You can read it online actually. It's either acute or chronic. Predisposing factor, long biliopancreatic limb, anticolic, gastrojejunectomy, non-closure of Patterson defect, one of predisposing factors. The incidence is up to 1% of patients. Actually, in our series, 435, we have 3 patients, acute syndrome, and we all revised them. So we took them to theater and we did revision. The treatment of this syndrome, because the blockage is proximal to the gastrojejunectomy, you just do Brown anastomosis, enteroenterostomy, and that's it. That should be sufficient. The other complications of MGB is liver decompensation, so liver failure. This is really serious complications. It is not related to malnutrition. It is not associated with diarrhea. Our experience with 2 patients, they presented 6 to 12 months after surgery. They have excellent weight loss. It's vague abdominal pain, nausea and retching, a grossly changed or deranged liver function test. Very worrying. I think I showed this slide in the previous talk. Liver failure is not specific for MGB. It can happen with any bypass surgery. The Roux-en-Y gastric bypass, Kamal Mahawar from Sunderland group, they reviewed the literature and they published a study with a mortality of about 60%, any patients who develop liver failure after Roux-en-Y gastric bypass. These 2 liver failures happen in our initial series because we've been very aggressive with patients. Everyone will have 3 meters biliopancreatic limbs. We have excellent weight loss, but 2 of patients fire back with liver failure. But they responded very well to the reversal and shortening of biliopancreatic limb. When it comes to the liver disease, in the last BOMS meeting, which I attended 25th, 26th of January, there is a professor from France presented NASH, about NASH and bariatric surgery. Very, very excellent, actually, interesting talk. The message is, if you put the laparoscope inside the abdomen and the liver is cirrhotic, don't do bypass surgery. Just give them a sleeve. The safest, we know it is not perfect operation, but it is the safest approach. 90% of our patients, we know they will have alcohol and non-alcohol fatty liver disease because you put a scope inside on the fatty liver. We know 75% they have feature of NASH, non-alcoholic steatosis hepatitis. These are the dangerous patients. These are the patients who punish you when they have complication. About up to 4% who undergone bariatric surgery. As I said, you put the camera inside on liver cirrhotic, don't do MGB. Or if you are aggressive MGB surgeon, then it should be very short biliopancreatic limb. My personal view, if the patients have liver cirrhosis, even child classification A, don't do MGB. Possibly sleeve is the best option. But why we have liver decompensation after MGB or bypass surgery? Different theories, none of them approved. Increased ketone production, active mobilization of lipid, release of toxic ceramines, rapid mobilization extra fat stores, surgical trauma. But we have to be careful with pre-existing liver disease. In Iraq, I think the problem of alcohol is very small and tiny one. In the UK, everybody is drinking alcohol, varying degree. So any patients who have excessive alcohol intake, or when you assess his liver function on the system, is deranged liver function test, we have to be careful with that. And we have to consider also the length of biliopancreatic limb, how much I'm going to give this patient. How long the biliopancreatic limb. But the lesson we learned from these two patients are don't do MGB limb, biliopancreatic limb more than 2 meters, although because you have to balance it, you can give them more than 2 meters with excellent weight loss, but they can punish you with protein hypoproteinemia, albumin malnutrition, or liver failure. You don't want to do that. If you have a preoperative finding of nodular liver disease and liver function is still normal, then you possibly can have shorter biliopancreatic limb. Rather than 150, you give them 75, for example. Most importantly, you diagnose the problem earlier, so you can act it earlier and the recovery will be better. The second complications of MGB is stomal ulceration. But our comparative procedure is Roux-en-Y gastric bypass. So the incidence of stomal ulceration is 4.3%. But the largest Rutledge series of thousands of patients, 2,400, is 4%. Is that significant? I don't think it is significant statistically. So both procedures are liable for stomal ulceration. What are the causes of stomal ulceration? Whether it is Roux-en-Y or MGB, acidity, foreign bodies, stitches, stable eclipse. Even when we started, we have put the notes from inside. We started from inside. Then after our stomal ulceration has increased, we decided to put the notes, stitch notes from outside. You start from outside the bowel lumen rather than inside. Ischemia is the most credible cause of ischemic ulceration. There is a nice study in obesity surgery from France about it. H. pylori infection, smoking, comorbidities, diabetes, and vasculopathy. In addition to that, some patients, they take in medication. For example, one of my patients, I did her MGB, and she lost about 70% of her excess weight loss in the initial 6 months, but she came in after 6 months with epigastric pain. This is the commonest presentation, epigastric pain. And sometimes they have vomiting as well. So did OGD myself. I never put any of my patients on somebody else's list. I do it myself. I know what I have done. I know exactly what I am looking for. If you put them on somebody else, for example, gastroenterologists, they don't know what is a stomal ulcer. They don't look for it. If it is not in your brain, it is not in your mind, you are not going to see it because you are not going to look for it. So any patients of my patients present with complications, I will do their OGD, I will do their colonoscopy. So this patient has been taking methotrexate for rheumatoid arthritis even before surgery. When we did the surgery, she continued to have methotrexate because of pain, and she can, but she's also on a small dose of prednisolone. So I have written to her doctor, to her rheumatologist, we have to look for alternative, and they put her on another medications. We stopped methotrexate, we stopped the prednisolone. I put her on sucralfate and lansoprazole 30 milligrams twice a day, and I put her myself on my list again in 8 weeks' time. And the ulcer has healed completely and her symptoms been improving. There is no pain, nothing. Very grateful, very good patient. The big question to us, scientific community, if we do research, we need to look for that. Is the stomal ulceration etiology is the same as stomal ulceration MGB to Roux-en-Y gastric bypass? Is it the same? I don't know, to be honest with you. So just back to the management of stomal ulceration, we have to remove the risk factors, as you know. I will put them on PPI medication for 3 to 6 months. Sucralfate is very good medications from our experience. The dose is 1 gram QDS. Because sometimes they can't swallow tablet. The tablets of sucralfate is very large, but in UK we got a solution. You can give suspension. And do them yourself. Put them on your list and do OGD yourself. Look for it, healing, progression. Some of these patients, they don't respond. They present with a blockage, stricture. Then you have to think of other options of revision. We have one patient from Roux-en-Y gastric bypass group who presented with a stomal ulceration as perforation. So he already perforated his stomal ulcer, and we have to revise him. Another serious complications after MGB is diarrhea and malnutrition. It is not specific for MGB, as I said. It can happen with Roux-en-Y gastric bypass. The incidence and degree depends on several factors, including complexity of operation, bypass operation, whether it is Roux-en-Y, biliopancreatic, BPD, SADI procedure, or MGB operation. The length of the common limb is important, the technique, and the complications. If we go to the literatures and we study the incidence of these two complications, it is quite variable. It's hardly there is any report of these complications after MGB, actually. I don't know. Possibly MGB surgeons are biased. They don't report these serious complications and they put it under another name of complications. But diarrhea malnutrition is being between 0.09 to 2.5% nearly. It's very small percentage, still significant. If we compare our MGB to Roux-en-Y, 4.7% of Roux-en-Y will have protein malnutrition, so it is not specific for MGB. Professor Bazuki suggested MGB to patients with constipation. A significant number of our patients, they have constipation. Actually, from our observations, we found that on our patients as well. Because they have loose bowel motion, they will be happier than before the operation. And the operation is going to sort out their constipation, excess weight loss, hypertension, diabetes if they have. We think the most important cause of protein malnutrition and diarrhea is the length of biliopancreatic limb. It is not only our view, but going to the literature, these are the evidence, the publications that support our view as well. We have 2 patients who had intractable diarrhea and all resolved by reversing bypass. They have done all well. But we investigated them before with imaging, biopsies, colonoscopy and biopsies, but nothing there. Even we have done MRI scan just to make sure it is not Crohn's disease. Sometimes you go and do the procedure you don't concentrate on the terminal ileum, that will hit you back. Well, I misdiagnosed Crohn's disease. If you have diagnosis of Crohn's disease before the operation, then you'll have better options for the patients. Recent study says even the patients diagnosed with IBD, inflammatory bowel disease, you can still do bypass operation. But possibly we are very conservative in the UK. If I have diagnosis before the operation, I will do sleeve rather than bypass. Our observation, these patients, they don't present yearly actually, 6 to 12 months after the operation. So why they didn't present yearly? We don't have explanation. It is the same length of the biliopancreatic limb. It is the same technique. Is it a hormonal adaptation? We don't know. So that's we need to look for. But we thought about it, about the common channel. Is it the common channel, the factor here? It is a material for research, and we are observing that, and we are studying it, and hopefully we can produce something in the future. Thank you very much.
Thank you very much. Question, please.
So, I think, just if you give me a minute. Yeah. Okay. Yeah. Question.
No question.
No questions.
One question. All right.
So, as you are, thank you so much for answering. Said you are working in London, and I think your patients are international. Okay. So, are there big variation among the patients from different nationalities? For example, did you do dietary or nutritional statement, cultural differences? For example, this complication, those patients who regain their weight or those who are exposing more to complications like hepatitis.
You have to consider the comorbidities, patient's wishes, age, BMI. So these are the factors that will dictate what you are going to do with them. But if I face this clinical scenario, I'll go for a sleeve. Yeah.
Thank you very much, sir. Thank you.
Okay, thank you.
Can we proceed to
I think-
next talk, which is about how MGB works, I think.
This is a pure biochemistry. As a surgeon, we hate this actually, because it is not within our direct thinking. But I'll try to make it as soon as possible. I try to make it as less boring as possible. So I'll be quick with the slides. So nothing to declare again, don't have any connection. MGB is a gastric bypass, so it is mirroring features of Roux-en-Y gastric bypass. It is not 100% effect as Roux-en-Y gastric bypass, but there are some features. If we come and see it, both a procedure on the screen, There is no roux limb in MGB, so it is only biliopancreatic limb. The length of roux limb in MGB is 0. The length of roux limb in Roux-en-Y gastric bypass is different from surgeon to surgeon. We used to make it 100 centimeter, 150 centimeter, depends on BMI. And we used to make the biliopancreatic limb between 75 and 150 centimeters. So by logic, doesn't need big brain to conclude that the mechanism, it shares some mechanisms of actions. It is not mini operation. The name, I think, is misleading. This is a huge, drastic, metabolic operation. It is not mini operation. It's just like a tsunami hitting the physiology of the patients and changing everything. We know there are changes in enzymes, we know there are changes in hormones, but we don't know so many things going on, we don't know. And it is a material for research. To put it short and nice and sweet, it is non-obstructive restriction. It works by non-obstructive restriction. I'll show you in a minute. It works by modification of gut absorptive function, as you know, and it works through hormones and enzyme and neuroendocrine connections.
Not changing the picture, man.
Sorry. Okay. Okay. So these are, I think, the most important mechanisms of actions. What is non-obstructive restriction? If we take the concept of the pouch we are making as a cylinder, we take it as a cylinder. So what is the volume? If we ask now the bariatric surgeon, how much do you think the volume of the gastric pouch we are creating in MGB? You will have different answers. If we do it using 45 millimeters cartridge, we'll end up with this volume as about 90 mils capacity. This is simple math. So the volume of the cylinder is by square radius by height. I put it in table to you simply. If we do it using 30 cartridge, then the stoma we are creating, because this is misunderstanding among even bariatric surgeons. They think if you use 30 stable, the stoma is 30 millimeter. It is not. This is the math. If you do it using 30, it means you are creating a circumference of 60. Use your math. It is 1.9 centimeter, the stoma size. If you use 45, as Professor Bazuki uses, 2.8 centimeters, the stoma size, the gastrojejunectomy. If you use 60, I'm using 60, it is 3.8 centimeters. But 2.8 centimeters is acceptable, there's nothing wrong with that. You can use 45. The other concept in MGB surgery, it is a smooth and slow food flow and satiety producing anatomy. We know from Gray's anatomy the diameter of esophagus is 2 centimeters. MGB pouch diameter is 2.8 centimeters if we use 45 cartridge, and you keep the same straight line. And the jejunum we know from Gray's anatomy as well, the maximum is 4 centimeters. So it is gradual, the food is going through the gradual increment in the pathway, food pathway. So it is a progressive increment. The other big question to us as a bariatric surgeon, where to anastomose? I've done it yesterday in different technique to Professor Bazouki. He's anastomosing in the mid of the stabler. So he's coming in the mid and do it side-to-side anastomosis. I am starting there, in the liver side of the face stable, because I believe in end-to-side anastomosis. Why? If you explore the YouTubes, you go to these meetings, you will find everybody is doing differently. So these are the commonest reconstruction. But if you see I don't think it's not coming on the screen, I don't know why. Yes. All right, that's fine. We'll go to the other slide. So if you do it side-to-side anastomosis, this is in the middle, you can see your pouch is about 15 centimeters. If you do it side-to-side, it means you are going to reduce the functions, physiological functions of the pouch by 33%. And the stoma will be nearer to the gastroesophageal junction, and that's carry risk of bile reflux. If you do it end to side, there is no reduction in the function of the pouch, and that's why I believe in that. I'm always doing it like this. But if you use 3 centimeters cartridge, then you reduce it by 20%. The other features of MGB is dumping syndrome. So it's about 18% of Roux-en-Y patients will have, dumping early and late. MGB expected to produce less degree of dumping syndrome, although it is still possible to have dumping with MGB. But we know when we create the gastric sleeve, we created narrow on a very small bougie, 33. Some surgeons, they use 36. And as you see from Laplace law, the smaller the size, the less likely will be the distension and failure. And this is why sleeve patients failed, because you make it a little bit wider and they extend it. And with the time, the pressure will increase, and then you laparoscope them after a period of time, you find, oh my God, what I have done. It's just like I haven't done anything. And you go to re-sleeve them again or to do revisional surgery. This is another talk. The slide from Professor Robino, he's a metabolic surgery professor, King's College Hospital, from his study. The second mechanism is actually metabolic effect. I believe in that, and as you know, every bariatric surgeon should believe in that. It's gut hormones and nutrient sensing, gut microbiota, bile salts. That's come recently to the focus of research. Gut microbiota, bile salts effect, glucose metabolism, and intestinal glucose metabolism as well, and the transport. The two major hormones, which is a playing part, I think, is GLP-1 and GIP. Professor Robino worked a lot on anti-incretin theory, and he thinks that excess of anti-incretin signal, possibly stimulated by specific macronutrients in the diet, it is causing insulin resistance, and that's why patients develop diabetes. Whatever operations we do as a bypass, that can modulate this and improve diabetes after surgery. So he concluded from his recent study, which has been published in Diabetes, Impact Factor 7, I think, very important, big journal, and it is the Journal of American Diabetic Association Society. They concluded that foodborne factors can affect insulin resistance. Then how do we know? The big question to this study, how do we know whether the changes are purely due to oral glucose or due to metabolic or hormonal enzymatic neuronal GI brain signaling? We don't know. But there are different signaling and sensing mechanisms. I'll go quickly through that. There is no direct study, actually, in the research that is studying hormones changes after MGB till now. And it is a project for research. But our expectation, and there are authors to support this, MGB is likely to reduce ghrelin hormone because in one aspect it possibly similar to sleep because it's very long and narrow, just the gastrojejunectomy here. So it's possibly it will reduce the level of ghrelin here and increase GLP incretin hormones here, GLP-1, GIP. But whatever happen, there will be enhancement of incretin effects, there will be reduction of anti-incretin effects. The other question, why we have anti-incretin effects? Why obese patients, some of our obese patients develop diabetes, some of them not? Why? It is the same mechanism of obesity. Why these patients had insulin resistance, the other patients is not? Why? So different theories. Is it genetic, epigenetic? Is it deleterious cellular effect of a nutrient excess? Is it underlying correctable abnormality of beta cell that when we do whatever bypass surgery, then that's going to improve and rectify the abnormality? We don't know 100%. But different pathways, including hormones, is playing part in it. It is very, as you know, very complex system. It is not like simple things. So this interaction, signaling between upper GI organs and also colon and terminal ileums, the lower GI, are involved in the process. Pancreas, liver. It is not only, we shouldn't be operating on a stomach and assuming that I do your stomach, you'll be fine. We should think of what's going to happen in the pancreas, what's going to happen in the liver, what's going to happen in the colon, terminal ileum, brain, is all single connected system that's produce the final effect. And whatever we are doing, the hormones will cause some changes in appetite of the patients. And these all work towards this. We notice from our observations, our patients not going to eat as they before the operation. Possibly they eat a small amount, they feel full. It is not only because of the size of the stomach, but it's also because in neuroendocrine signals and manipulation and adaptation. I'm just going to go through bile salt and bile acids recently. This is part of focus of research. I'll go quickly through that. Microbiota, we have about 1,200 types in our intestine. So research has found that these are playing roles in the weight loss. Different studies, this is one of the studies. Just go quickly through it just to shift your attention to it. Bile salt, bile acid reduce metabolic complications following bariatric surgery. This is another study. I'm going to go quickly through this because it will be boring to the surgeon actually, and I hate it. But in MGB, the biliopancreatic limb is the monster that make the changes, and we have to consider that for our patients. It's the main effector actually, the main mechanism of action. It comes from the biliopancreatic limb effect. And its effect, it depends on its length. The longer the biliopancreatic limb, the stronger the effects on the patients, the higher the complications. So you have to balance it. And sometimes the balance will be slim. And that's why you have complications. So just be careful. But the other point of research and consideration is the absence of raw limb in MGB is a factor as well to produce the effects. We don't know. Is the common limb length is a factor. It doesn't affect, actually. Studies has shown common limb length doesn't affect type 2 diabetes resolution. It is the Roux and the biliopancreatic limb, Roux-en-Y gastric bypass. Is the common limb have effect on excess weight loss? It doesn't have. Studies have shown doesn't have. Is alimentary limb, Roux-en-Y gastric bypass, play important role in excess weight loss? It doesn't have from studies. The third mechanism of action of MGB is modification of gut absorptive function. I'm going to go quickly through that. But the final stage is the final results of what we have done in our hands to the patients to change the anatomy, intermingled with genetic constitution of that patient, intermingled with his social background and his dietary habits and psychology. Thank you very much.
Any question? There is no question, I think. I have a comment for this lectures. Yes, there is great studies about hormonal change, especially by who specialize in nutrition. And they saw not the change in the patient himself or in the her daughter, new daughter, or the siblings or new siblings of them. They saw بمعنى لو شافوا أطفالهم اللي قبل العملية يختلفون عن الأطفال اللي يصيروا ورا العملية. حتى البادي بلك مالتهم حتى التشينج صار. هذا يعني دائما نستذكر يعني القرآن الكريم بسم الله الرحمن الرحيم وخلقناكم في أحسن تقويم. Any change in the body will change the system itself. Thank you very much. يمكن هاي المحاضرة الأخيرة على ما أعتقد. نشكر أخواننا بمحافظة النجف نيابة عن أخواني من المحافظات الأخرى وإن شاء الله تبقى النجف مركز وعاصمة للكل إن شاء الله. والشكر الجزيل للدكتور عبد الزهرة على المحاضرات القيمة اللي قدمها إن شاء الله.
It's a great pleasure. I thank you very much for audience, and I really feel happy and honored and humbled by kind invitation. Ustad الدكتور علي محمود الشمري, Ustad الدكتور محسن الظالمي, Ustad الدكتور صفاء الدين سالم, all the peoples and brothers in the Department of General Surgery. I really feel very, very happy contributing even little to Najaf and to scientific activities in Jabir bin Hayyan University, Kufa University. And I am your servant, my colleague in the department. They have my details and you can contact me. If you visit UK, I will be more than happy to meet you and to help you or advise you whatever things, not only science, but it's on social, anything. Is the research activity. So I know especially for junior consultants, junior colleagues who are interested in research, I have good experience. I don't want to say it's excellent experience. Over 13 years being working in the UK. When I arrived UK, I don't have single publications or research projects, and every interview I went there, I went for 11 interviews, they didn't give me the job. So these interviews all over the UK. But one of the questions I quite remember in the interview, do you have any publications? And my answer is no, I don't have. And what is publications? So my advice to the junior colleague, please be active in research and publications. And it is hard work, I agree with everybody. It is hard work, it's time consuming. But I think if you start it early, it will be much, much easier. So I am here to support you. My colleague got the details, my details in the department. Anybody of you have research project, please do contact me. I must say I don't have time. I must say this, I don't have time. But if you contact me, I can create time for you, even from my sleep. So just just have low threshold to contact me, all right? And I wish you all the best. I hope I can do it again, come to the UK, because last time I have been here 5 years ago. It's a long time. So even I didn't recognize some sites of Najaf city, because it is just rapid transformation. And it is no secret, when I came, I didn't know my family house. I didn't know how to get there. I lived in the house for ages, and I didn't know how to get there. So, inshallah, I'll be there next time with you, but feel free to contact me for anything. Thank you so much. Thank you.
بسم الله الرحمن الرحيم. بكل سرور وفخر حقيقة نحمد الله سبحانه وتعالى ونشكره على هذه النعمة. نشكر الأخوان جميعا ممن شرفونا وحضروا ونوروا هذه القاعة وهذه الفعالية. الشكر بالأخص للأخ الأستاذ الدكتور عبد الزهرة للجهد الكبير الذي حقيقة قام به وأفادنا كثيرا بمحاضراته ليومين متواصلين وكذلك لورشة العمل. الشكر الكبير للأستاذ الأخ الدكتور عبد الرضا فازوكي لحقيقة نفسيته الطيبة وكرمه ومشاركته الفاعلة، وندعو الله أنه يصل بالسلامة اليوم، هو طائرته يرجع إلى طهران. الشكر إلى جميع الأخوان اللي شرفونا من المحافظات العراقية العزيزة، بالخصوص الأخوة من الموصل، الأخوة من بغداد، البارحة كانوا مشرفين واليوم دكتور علاء موجود، الأخوة من بابل، من كربلاء، من باقي المحافظات، من واسط. نعتذر عن أي تقصير إذا كان يعني مو في مقام الأخوان. الحقيقة موضوع حيوي جدا. We learned a lot during this short time, 2 days, from our dearest expert colleagues, and regarding our situation in Iraq, I would like to emphasize on the database registration, and for the second, I think very important, is a teamwork. One should be not alone to face a big issue. It needs a very strong infrastructure. It needs cooperation. It needs really establishment of specialized units to have good outcomes. And as our colleagues say, it is a multidisciplinary work, and every effort should be combined together to make it succeed. This is what I get during this time, and also every patient should be discussed as a separate, and the problem should be managed in specialty. And the surgical decision is a matter of agreement between different parts of the group, of the team. My great thanks to all who attend, and إن شاء الله نلتقيكم في لقاءات مقبلة. أشكر الكرم الكبير اللي وافانا به دكتور بازوك، يعطانا رقم تليفونه والويب سايت مالته و he is ready to communicate. دكتور عبد الزهرة حقيقة تواصل مهم للنجاح لأي شخص، وإن شاء الله نكون نواة لتواصل أكبر وأكبر. وشكرا جزيلا، وأعتذر عن حقيقة كل شيء أخاف صار فيه يعني أي ديفكت. شكرا جزيلا والسلام عليكم ورحمة الله.